online, Dr. Latsios, Dr. Toutouzas, Dr. Dardas, and right here with us, Dr. Katsimagklis and Dr. Spilias, as well as Dr. Papadis here with the heart surgeon of the panel. Minimalistic TAVR. As soon as we're ready, we can fire the connection. Go ahead. And then right after that, Dr. Toutouzas is going to give us a lecture on Bicuspid TAVR. Okay, we already see Dr. Iakovou and co-workers at the Onassis Heart Center. The names are, let me read them all, Iakovou, Leontiadis, Kosmas, Papadis, Falara, Balanika, Smyrli, and Papageorgiou. Go right ahead, Yanni.
Okay, hi George, good afternoon to everyone. I hope you can hear me.
Very well, very well.
Yeah, we can hear you.
Good, excellent. So it's, I couldn't find anything better than a minimalistic TAVR after the lunch, right? So it's minimalistic, but not simplistic. This is a reference to the discussion that we had earlier in the conference with Arik. So let me introduce the team. Is Dr. Voudris, who we all know, Yota, Martina, the head of the program, Lizetta, okay, and George Bobas from Medtronic, and Anna Smyrli, anesthesiologist, and Lucinel, nurse anesthesiologist. So we're really happy to share this case, and Dr. Kosmas will present the details.
Good afternoon from me. We're going to see a minimalistic approach of TAVR procedure. The case presentation is about a male, 84-year-old with gradual worsening effort dyspnea and 2 episodes of syncope, arterial hypertension, dyslipidemia, and diabetes mellitus with implantation of permanent pacemaker and high value of creatinine. Here you can see the surgical risk scores. From the screening coro, there is no significant coronary artery disease. And from the screening echo, you can see preserved left ventricular fraction and AV Vmax at about 4.2 and high gradient. Here you can see the screening echo and the screening coro. Left coronary artery and right coronary artery. From the CT angiography, you can see all the measurements that we usually take and absence of severe calcification in the aortic valve and promising femoral access. Here we used the heart team of our hospital decided that catheter aortic valve implantation should be the optimal strategy. And now I'm going to show you why we preferred the left femoral artery. Here you can see the right femoral artery from the ultrasound video. You can see a calcified rock here, and now you can see the left femoral artery. Long and short axis, and then here is our anesthesia, xylocaine, and then you can see how we puncture the vessel. Okay, here we have the puncture, and now we're ready. And now we're ready to go back to Dr. Iakovou.
Okay.
Well, let me ask Dr. Spilias, University of Miami, do you do routine femoral ultrasound access?
Yes, we use ultrasound and fluoroscopy at the same time to mark the exact height of puncture based on the femoral head. And we also use ultrasound to ensure that the puncture is central.
This is so important what you just said. because the vast majority of operators are just using ultrasound, and ultrasound never ever gives you the exact information of the height regarding bifurcation, etc., like angio at the same time, not cine at the same time, fluoro. So I think that the combination is very, very important.
I mean, at the same time, I have to say, we already have the CTA. You already know the relationship with bifurcation with the femoral head.
But you are not doing the procedure with the CT online. That's what I mean.
Yeah, but if we know the bifurcation is at the lower third of the femoral head, we can just go by the femoral head.
Yeah, but you have many patients
in
which it's in the middle. And you want to stick exactly between the bifurcation and the head at the top.
For a minority of patients, I think we can do it. But over here, you can see everything is low. Look at the CT.
In this case, you're right.
Okay, very well.
Quick point.
Papadis.
So, quick point. When I first came from the U.S. At IEA, we were not using ultrasound. We were just going based on fluoro, and I shared my U.S. experience with the team, and slowly we got acclimated to it. I think for cases that are easy and clear-cut, no difference. But there are cases that have specks of calcium, and you need to be able to avoid the calcium. And I think fluoro is, not going to be able to show you if it's anterior or posterior. So if you have to get a very precise area, I think ultrasound in combination with fluoro is the best bet.
Yeah. Dr. Latsios, what's the practice in your center?
Hello, thanks for the invite. Well, the practice in our center is we use fluoro dedicatedly. Perhaps we were because we started like that. We are very accustomed to that, and if we combine the fluoro, the live fluoro,
stay with the fluoroscopy while people are speaking. Do not change off the fluoroscopy. You're welcome to use picture-in-picture to show the face, but stay with the fluoroscopy, unless we lost signal.
Okay. So what we do is we combine the data we get from the CT with the fluoroscopy.
Okay, we hear you. Go ahead.
And okay, so that's the idea. There are also advantages on that. The advantage is we do not lose touch with the way we puncture or with the way we do crossover. Okay, I understand there are mounting preference, if not evidence, to use combined fluoroscopy with echo-guided puncture. The more you use, the better you have. But I haven't changed my practice in any times I've used fluoroscopy for arterial access. Venous access is another thing.
Dr. Dardas, what's your practice there, very briefly?
Hello, for me as well. Our practice is ultrasound and fluoroscopy in all our patients, and also if we go from the other side, in order to do the crossover, we always puncture from the other side with ultrasound as well.
Yeah. Okay, very well. Let's go ahead with a live case, please. Don't lose it. Keep this film all the time. So I see they're already in the LV.
Yeah, so we had to fail quickly with an AEL1. We changed to AEL2 because it's somewhat horizontal, and the heart, and also there is a big coagulation in the aortic arch as well. But we use the Landerquist, so everything has been straightened out right now. So I think it's very important that the ultrasound, when we change our practices, I think it's practice changing actually, despite there are many very experienced operators out there who are reluctant to change their practice, but I suggest that this is very important. So for this, for instance, this patient was scheduled for, after the CT, he was scheduled to do a right femoral approach, but we spotted the big chunk of calcium, which is quite larger than seen in the CT. On the inferior wall, and maybe obstructing the way of the proglide. So we decided to go to the left femoral and do a little bit higher puncture and to avoid the calcification there as well. So at this point, so it's 1.8 milligrams of creatinine, so it's a very impaired renal function. So would you predilate this patient? You see the gradient is not much, it's 4.2 meters velocity. Would you predilate, George?
Well, thank you. According to where the calcium sits and according to the velocity, I would go with a direct TAVI.
Direct TAVI. Okay. Kostas? Kostas, would you predilate? You did, Hippocrates did this nice study, the direct study.
What's the calcium score here?
Yes, that's the question. What's the calcium score? If it's very increased the calcium score, we usually predilate. Otherwise, we use the minimally invasive approach without predilatation.
Yeah, of course. I'm not sure about the calcium score. It's not that calcified. Maybe less than 2,000.
So then we avoid it. By the way, Dr. Kilic has joined us, and he will enter the discussion in the subsequent round after he settles down a little bit. Thanks for joining, straight from the airport.
Thank you.
So I think go ahead with no predilation, no? Is that the
We'll do
consensus,
it with
Ari?
no predilation, yes.
Ioannis,
Yes.
like everything in TAVR, with your experience, everything becomes the decision-making more complicated because we know more, okay? Now, like Hippocrates said, right? As much as I know more, I see that I know nothing. So, regarding your question, I think that any patient, the decision-making is being advocated by many things. One, yes, of course, how much calcium there is, how much stenotic, this is obvious. Then the calcium is our so-called enemy, but with the self-expandable valve, it's kind of a friend because it stabilizes the valve while we are implanting it.
Yeah.
But in your decision-making, if this is a patient in which you want very much to do a very high implantation, you don't want to need a post-dilatation because it's going to be much more dangerous. If this is a patient that you can implant it like 4 millimeters depth with no danger of RBBB and no danger, etc., and according to the sizing, of course, you know. So I think that you know the case, and predilatation, whether or not to do, is not just how much calcium and how much stenotic it is, but the chances and the need for post-dilatation and what it means. That's my way of thinking.
Yeah, this is a great point, Derek. So thank you. So another information that just came, so we have 195 ACT. At this point, would you give ACT in this patient, heparin, more additional heparin in this patient or not? Because in these patients, we try to be as simple on the low level of the coagulation. So we are aiming in approximately 200, actually less than 200, because we anticipate this procedure to take no more than 30 minutes. So that's our take. So in order to minimize vascular bleeding, we tend to under-treat this patient in terms of heparin, and we didn't see any difference in ischemic events or anything.
I think that if the case is straightforward and you think that you are going to implant and go home, you cannot, but...
Yeah.
But if it's going longer, then you add one.
Can I comment something on the predilatation?
Yes.
Yeah.
Well, sometimes it's not only the calcium, but some of the valves are very fibrotic. And in these cases, no matter how calcium there is on the valve, I think that predilatation is our default strategy anyway in our cath lab, but predilatation stabilizes the valve better.
I have to agree that you have to take into account that when you predilate, with the balloon, you have 5 to 10 times the newtons that you give with the direct implantation. So it's 5 to 10 times more the force with the predilatation as opposed to direct implantation. So this is a very nice comment, but I think yes, we can try. Maybe we do post-dilate. Maybe we post-dilate later in this valve.
For the
predilation issue, also there are some important points. If this patient, for example, a patient had a bicuspid aorta, we must do predilation. And if a patient had a horizontal aorta, we must also do predilation to change the angle. And I always look at the hockey puck views. If the calcium is over 2/3 part of the circle, and especially very dense calcification at the point of non-coronary cusps, and also that means predilation will be useful to see what will happen during the valve implantation. And for the predilation, it is very important to select the appropriate size of the balloon. It must be below the minimal diameter. That must be also taken in account from the CT views.
Okay. So this is a good point, Theo. So thank you for that. So when we hesitate whether or not we have to do predilatation, we always try to err on the safe side, so we always predilate. But in this situation, we've crossed relatively easy, and we don't want to give some more dye in these patients. Can you hold the one? Yeah, okay. So you can see here, it comes from the outer curve. Okay. Μπορείς να κασίσεις να κρατήσεις. So at this time, when we cross the valve, most of the times we tend to retract the wire a little bit just to avoid the tension on the aortic arch, because this is the time that we know that more the emboli come from when the valve crosses the aortic arch. So you see, it's not the best trajectory. We're losing the wire a little bit. We have to press the wire a little bit. Okay. 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 We have the pressure. Okay. So the wire not the best position. Okay. Can you push the wire a little bit? This is the cusp overlap, Martina. Are you sure? Okay. 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 Okay, let's go. Πάμε λίγο αίσθηση. So it's quite, yeah. Okay. So we have to push the wire a little bit, Vasily. Inside. Okay, and then I'll push it a little bit. The valve is coming out. Okay. Okay. Can we place? Okay. Can we go to 80? 80? Okay, 100. That's perfect. Okay. 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 Πάμε 120. Ωραία.
Yannis, I think you are looking for the cusp overlap angle.
Yes. We are trying to figure it out. So πάμε λίγο πιο κοντά και λίγο περισσότερο AP. Okay, πιο κοντά. Αλλά πιο ράου.
I will ask to.
Okay, all right. I think maybe we're in a better position.
Do you use also near cusp overlap views?
Okay. Να γράψουμε.
I don't want to interrupt their job now.
Yes.
But no, you concentrate we're talking nonsense here, okay? You concentrate on your job.
Okay. Πάμε να ανοίξουμε, Βασίλη.
But I think that,
Πάμε 120.
as you just asked, I think that the biggest mistake of our operators is to go strictly to a dogma. There is only 3 cusp and cusp overlap, nothing else. And this is wrong.
Okay.
So near cusp opens a wide spectrum, and that's the way I'm doing. And I think that one of the most important things that an operator should remember is not to panic when the patient is going down with his blood pressures. It's not catastrophic that the patient will be 30 seconds with low blood pressure and you move the eye right and left and see the perfect position. So you're absolutely right.
I think it's very important, as you said, when you're on the cusp overlap or near cusp overlap, to make sure there's no parallax, the parallax of the valve to be completely.
Of course.
Πάμε. Εδώ. Inject.
It's a case of it's a difficult implantation, you see.
Yeah, so it's not a proper alignment.
How
Yes.
unstable the valve is.
Yeah.
And it's challenging.
Yeah, it's good. You can use some more injections in this situation. Spend a little dye to be sure, so you don't have to recapture. Looks good. Keep going. You can go fast pacing. To slow down this up and down movement, you got to go fast pacing before it pops up. I can't tell. I wish it was more magnified. I can't really tell the
Stop. Ωραία, κράτησε εδώ. Πήγαινε 80. So you see, it kind of self-centered a little bit. Maybe we can see how it behaved. So you see, there's not a lot of calcium. It opens quite nice.
Well, that's good. You're near zero implant, I think.
So we have to check for stability. It's not. When I see this bell shape.
Can you give a small injection that we can see how?
Maybe I'm not very happy with that. So.
And it should be better to control it for the final release was in left anterior oblique to see the depth of the valve.
I think it's fine. We just have to release it at 180 with a push.
Wait a minute. This is an RAO caudal?
Yes, it's
this is the...
Please.
Okay. If the blood pressure is okay, try to take it to LAO caudal. LAO caudal always shows you an exaggeration of the head.
So this is the coplanar view.
Yeah.
Maybe you can do the spider view that Arik wants you or
You understand what I mean? The LAO caudal will show
very
that
important.
it is higher. So don't be panic.
So if the problem is that when we go to spider view, we can check. Let's go spider a little bit. So you take out the parallax, which is high here. Don't give any dye here. Don't give any dye.
You see?
Okay.
You see?
So you see it's very high here, but it's not accurate because we don't see.
Yannis, the only question is how important it is to implant it high in this patient.
Yeah, so there's no actual reason, I think. Because
so if it's not, and it's just in order to show that you're good, it's
no,
too
we
high.
don't do that stuff. So yeah, that's why we discuss. So maybe we can place it a little bit lower.
Yeah.
I agree, probably, but yeah. Can we go cusp overlap?
And while he's doing it, I wanted to tell you something, guys. You know, the high implantation with this cusp overlap, etc., it became the holy grail, that it is the most important thing in implantation. And we didn't realize there is a cost, because in patient that doesn't have huge sinuses and doesn't have very high coronaries, the penetration to the coronaries later on is much more difficult.
No question about it.
And TAVR is almost impossible. So I think that putting this as a target in order to show, hey, I can implant high and lower pacemaker, it's wrong. And this wrong attitude is being dedicated for quite a long time.
So we are contemplating, Arik, with Vasilis, and maybe we can discuss, maybe, so if it's a valve with no pacemaker inside, we would leave it here. But maybe since we have the pacemaker, maybe we can have an extra more protection to place it a little bit higher, maybe aim 2 or 3 millimeters lower. What do you say, Vasily?
Yes.
Arik, do you agree?
I totally agree. The patient has permanent pacemaker, and unless she is on the truly upper border of the size, which she is not, why won't you implant it like 3 millimeter deeper?
Yes, we'll try to do that.
Don't you agree?
I fully agree. The patient had a pacemaker, and there is no need to do a full cusp overlap technique in this patient. Maybe, as you show us, one of the other thing is the commissural alignment technique that the capsule.
Okay, start.
Okay. Πάμε 100.
Capsule head marker. Maybe you can control it on the cusp overlap view and then release the valve.
You need to magnify more.
Go a little bit now, we're a little bit high.
Try
Should
to
inject a little bit. So we're very low now. The pigtail at least is in proper position. So I'm going up a little bit. And then we can start from here, I suppose. Πάμε 100. 120. Και εδώ μέσα. Σύρμα. Okay. No. So it's very important for the second operator at this point to have a proper control of the wire. So, okay.
I hardly see the valve, you know.
Okay.
Yeah. No, it's lower.
Παρασδόξε λίγο το σύρμα μια ιδέα μέσα, Γιώτα. Okay, ωραία, πάμε.
You got to use some dye over there and see it. We can't see.
Yes, we will, but as 1.8.
Again up. It's very high again.
Yeah, we'll see.
Yeah,
I think it's
go ahead right there, very fast.
Not
you
bad.
have to pace faster.
Πάμε
Because it's moving
120. 120. Θα το κάνουμε σιγά σιγά, Βαστήλο. Σιγά σιγά, παιδιά.
Maybe you can start opening in left anterior oblique caudal valve rather than cusp overlap.
Ναι, πάμε, Βασίλη. Πάμε.
Yannis, why don't you try like 120 pacing, which will stabilize it and make it much easier?
Okay.
You see, this is just
So,
one
πάμε
VPC.
120.
Yeah.
Okay, κάτσε λίγο, μισό λεπτάκι λίγο.
Τώρα τα έπιασε. 120.
So,
Let's recapture and consensus here is you have to recapture and then go in and pace much faster in order to create more stability. Everything seems to be moving quite a bit and magnify more. We cannot see. You don't need to see the arch. Magnify so we only see the valve and the LV.
We're just losing the position of the wire and the pacing is getting a little bit erroneous. So now, if we work like that, I think it's going to be fine.
Permanent
Okay.
pacemaker.
So now we have proper capsule. Okay, let's inject.
Are you pacing from the pacemaker or are you pacing from the LV wire?
From the wire. Yes.
If the patient has a pacemaker, why don't you pace from the pacemaker? Make your life easy.
I think it's more controllable, George. Yeah.
Well, that's why they're a little bit erratic, because the wire loses. Now we get it. Okay. Things are beginning to make sense. Pace a lot, though. Pace a lot.
So unfortunately, the sedation. You see, as the comment of Dr. Weiler doesn't help sometimes because patient is snoring. So it's, yeah.
You got to magnify. You got to be able to say, okay, pace faster now, pace faster, and keep opening. And again, more dye. Give it again dye. You need to spend the dye because it's been too many times that it came up. Inject.
Πάμε λίγο γρήγορα. Okay. Ωραία. Πάμε λίγο, Βασίλη. Δεν πειράζει, Βασίλη. Πάμε λίγο να ανοίξουμε.
Rapid pacing, maybe much more.
100.
What? You need to,
Go to 140.
consensus is to go to 150.
150, yeah.
Go 150 and give some dye, please. We have to see there. We can't see. I don't know how you can see.
No, it's pop.
Okay, so we need to stop here and then just place some dye.
You're already up again. I think it's already, it seems that it's already up.
Yes, it is.
Yannis, maybe you are always using the cusp overlap weave to start the implantation, but we agree that there is no.
The first one.
But,
I don't know if you can hear me, George.
but
George,
there is no
I think
need to start with the cusp overlap technique. Maybe you can use the traditional method, left anterior caudal weave, and start at that position. Much more, it will be much more
I
safe.
fully agree with. I fully agree with Theo. I don't know if you can hear me, George.
Yes, Kostas.
My suggestion is to go a bit deeper, high rate of pacemaker, and change the projection because they have to use the traditional one with the 3 cusp overview.
Yeah, maybe.
And probably try to pace at the target like blood pressure, like systolic of 78.
Pace faster.
Pace of the target systolic.
Pace faster, magnify, use dye.
The point that he's using the wire to pace is because pacing from the permanent pacemaker has a long leg, and the control takes much more time. That's the reason that Ioannis decide. And
Πάμε λίγο πάνω, παιδιά, να βλέπουμε. Πάνω, να βλέπουμε το pigtail.
Where is the pigtail, though?
So we had to retract the pigtail because just to avoid entanglement with the. Okay. Εδώ λίγο το υδρόφυλλο μου δίνεις λίγο γιώτα. Λίτσα. So it's not minimalistic anymore, but it's anyway, it's learnful.
Are they happy with their pacing?
So at this point, we have recaptured 2 times the valve. Would you change the valve and, or would you consider?
This is the last time.
Off-label. How many have they done? 3? They did 3 or 4?
I don't care.
No, it's, but actually sometimes much more.
Look, this is a challenging, I said from the beginning, if you remember, it's a challenging one. It's like implanting in a pure AI case. You see no calcium, no stability. It is jumping, and I think we should just let Ioannis work. He's experienced enough, and he'll do the job.
Yeah.
Well,
Maybe sometimes the valve is fibrotic. You see there is not a lot of tissue. Maybe pre-dilatation in this situation would be prudent. So we have to do a little more.
why don't we break? Why don't we break here so Yannis can change a valve, prep a new valve, and then we'll get back. Let's go to a Bicuspid TAVR ASK presentation by Dr. Toutouzas, and we come back when the new valve is prepped.
Να το κάνουμε,
All right, thank you. Dr. Toutouzas via internet connection. Please connect and go ahead.
Okay. Έλα λίγο να κάνουμε λίγο. Πρέπει να είναι σταθερό αυτό.
Slide control. Please get the slide of Dr. Toutouzas up so he can start to stop.
Το τραβάμε, όταν τα βάζουμε κάτω, μετά χάνεται και πρέπει να είναι σταθερό. Πρέπει να είναι σταθερό. Κάτι έτσι, Βασίλη, μπορείς. Ωραία, πάμε παιδιά λίγο.
Ας βάλω και εγώ.
Ναι. Θα δοκιμάσουμε έτσι, άμα δεν μπορούμε να μπει εδώ πέρα. Θα βάλουμε... Έλα, πάμε λίγο με 100.
Δεν ξέρω φύγουμε κανένα.
Go back to the cath lab.
Can you go back to the cath lab? We're sorry. We'll be back to you, okay?
So we're just making a
Okay. We're with you.
If if we're not able to place it correctly, then we'll change our practice. Okay, so 120.
Please, pace 150. Pace 150 and keep going.
150. Okay. Yeah.
Okay.
Let's start. Start releasing. Injection, please. Injection.
Yes.
Good. Keep releasing.
Ωραία, ό,τι κάνω εγώ εδώ πέρα, σου λέω εγώ.
That's very high. Advance it a little bit. That's very high.
Okay, κάτσε εκεί.
Very high. Very good. Very good now. Keep going. A little die.
Έλα, γράψουμε.
Injection.
Okay. I think it's better like that.
Okay, keep going, keep going, keep going. Keep going.
Μην του μιλάμε, παιδιά, μην του παίρνει βαθιές ανάσες.
We gotta go fast now. You gotta release fast now. You're in the fast release phase. Injection again, please. Keep going and pull it up a little bit. Push on the wire.
Λίγο το σύρμα, παιδιά.
Let's go fast though.
Okay, πάμε λίγο εσύ. Το τράβηξα λίγο πίσω. Πάμε εσύ.
Injection again. Keep going fast. Injection while he's going fast.
You say anesthesia doesn't help at all
Keep
here.
going. Stop there.
Okay,
stop with a push and pull the wire a little bit back. This is going up again.
You should patient the snoring, so
It's okay.
I think that's good.
It's okay. Just pull the wire a little bit so it won't push it
I
up.
think it's fine. Let's see the Coplano view. Πάμε τριφύκα view.
Well, as we said before, given that there is a pacemaker already, there's a lot of movement up. We accept 4 millimeters below implant.
It's good.
So, hemodynamic wise,
Probably a 6
I would be happy with this.
below implant.
No. It's okay.
No problem. It's okay.
No.
It's better to
when it will.
pull back the wire and
Okay, να γράψουμε λίγο. Να γράψουμε και ακούστε με λίγο.
Pulls back this wire, he cannot pace. That's part of a problem of this wire.
So let's see if it's if we moved a little bit.
It doesn't need to pace now.
So maybe.
I don't think it's going to be a favorable answer. I think I don't want to ask a question, I already know the answer. So, but the practical problem of this approach now is that if you're going to pull the wire, you lose the pacing.
But it doesn't need a pacing anymore now.
So maybe we need to pull the wire a little bit.
Yeah.
You have to pull the wire all the way then and release with a little push.
Can you do another injection? I think it hasn't moved, so
It keeps
it's
moving up. Please release it before it moves all the way up.
You see, it's really unhelpful, the anesthesia here. So it's, this is a good example, of what to do and what not to do. Πάμε 150.
He's not capturing. So don't worry about it. It's not capturing. Just release with a push.
If you don't pull back the wire, maybe much more fast pacing will be.
Πάμε πολύ αργά. Πάμε Βασίλη, το βγάλουμε. So we are fast pacing 150. We'll go to 160. Πάμε 160.
Looks like you connected a little bit, no? One pole is connected, no?
80.
One pole is connected.
Yes.
Yes, we know.
Very
So
careful.
we have to, no, hold on a second, Vasily. We have to place.
I think
So
it
you
released.
see-
You pushed a little bit and it released. Watch the nose cone.
Pull the wire back a little bit.
Hold on a second, hold on a second.
Centralize, yeah.
All right, advance the wire now. Okay, let's do okay, let's go back, marry the two and connect the two and then do the angiogram. High volume angiogram because the pigtail seems to be very high up.
Yeah. Δώσε λίγο το σύρμα.
What are your thoughts on pulling the wire back to centralize the nose cone before the final release?
Wait, yeah, I think, yes, we have to pull the wire back.
That's
If you pull
basic.
the wire back, then the wire goes in the inner curve, so that, in this
Βέβαια,
case,
ροχάλιζε ο άνθρωπος.
interferes with the top of the valve. So in this case, it's a little bit of a situation.
The only thing is that I never ever pull the cone before I'm looking at the orthogonal view.
Yeah.
Because we had experience mainly with
Έλα,
the
πάρεις πίσω,
34, mainly with the 34 millimeter, but with the 29 and 26 as well, that there was a non-perfect expansion of the valve, and it could pull it back. So before pulling the nose cone, I always take another orthogonal view to see that everything is spread appropriately.
Yeah, and especially when you have more than one recaptures, we need to make sure there's no infolding anywhere exactly.
Yeah, that's what I'm talking about.
Yeah.
Most of them were with the 34 valve, but we had experience with 29 and 26 as well.
So we can inject here to. So in terms of, yes, it's very high, the dye is very low, very little, but we can make a measurement here. And να γονάτσουμε λίγο και βάζουμε ένα πικτά να μετρήσουμε ένα gradient. So we can make a hemodynamic measurement here. Βάζουμε το σικάρι, κρατάμε το πηγή στο μέσα, το στήρμα μέσα. Ναι. Πάμε λίγο να δούμε το nose cone λίγο, Ματίνο. Να δούμε λίγο το κενό. AP, να δούμε λίγο, Ματίνα. Το nose cone θέλουμε να δούμε. Πάμε λίγο κάτω. Συγγνώμη λίγο. Maybe we need to open it up a little bit. Okay, πάμε πάνω, Ματίνα. Ματίνα.
I don't know why.
Is it possible we can use a higher magnification here so we can focus a little bit more in the valve? In this
Yes,
final angiogram?
we can.
Yeah.
Can. Martina willing, yes.
By the way, in the meanwhile, I truly don't understand why by the end of the procedure, maybe I'm wrong, okay? By the end of the procedure, I'm going over this wire with the pigtail, I'm taking out the wire, I'm measuring pressure. If it's good, I'm going with the pigtail out and I'm injecting without this heavy-duty wire that sometimes creates by himself AI. And again, I see people who are injecting with the wire inside. Look, you know, when you're talking about accurate, yeah, sometimes it's a problem to go against his tide with those long wings. But here, there's no problem, or with Edo, there's no problem. So why to leave the stiff wire?
I never leave the stiff wire, just like you. Put
So
a
you mean
pigtail
to exchange the wire before placing the
and then
pigtail?
the final injection with pigtail, because it causes central aortic regurgitation, especially in balloon expandable valves also.
And at what point do you do a transthoracic echo after deployment? Do you give it 5
Only
minutes?
only in those cases that I am hesitating whether to post or not to post, but as time moves on, there is no hesitation anymore, because if there is a question, you don't compromise anymore on mild leak. It's enough. So the main use of echo in the cath lab is to see whether there is a tamponade or complications, yeah.
Well, it seems to be a very good result. I mean, have we flushed the channels though? The EDP seems to be...
Πρέπει να πάρουμε ένα 0, παιδιά, και στα δύο.
And for the evaluation of aortic regurgitation, hemodynamic evaluation is also important, like aortic regurgitation index. So the hemodynamic evaluation, diastolic pressure.
Yeah, but this has limitations, you know, in patients that had AI before. The memory keeps the tracing as if they still have. Notice that. Second, if the patient is bradycardic, the tracing will always show you a worse AI index. So, yes, in general it's good, but...
So I think it's an issue of the pressure we always... But let's see if there's any gradient like that. Like Ari did. You see there is still a discrepancy, so there is no gradient. So there is no gradient, you see some...
Yeah, let's inject. We have both pigtails. I'm going to inject from both pigtails or only one of them?
No, we don't need. It's minimalistic as planned. We need only one. So let's inject. Πάνω στο cusp. Okay, πάμε. Έλα. I think it's a small AI, but we can check with the echo. I wouldn't. Maybe we could do to the coplanar. Ωραία. Ηλία, να κάνουμε ένα υπέρηχο. Okay. So let's do an echocardiogram and see, but I think I'll be fine with that.
What do you think? Post-dilation, Ari? I think smells like a post-dilation.
So diastolic pressure, I don't know if you can hear me, George. It's 52, it's coming up.
I think that the AI looks like mild, at least, and I don't think there is any risk of post-dilatation. So if you are hesitating whether to do or not, I would. But I don't know the patient and...
Yeah. Έχουμε το...
It should be better also to wait a little bit because nitinol enlarged, so I don't see it.
Let's see by echo the
should be better to diastolic pressure.
Although the echo seems to be limited due to body habitus.
Well, not the best image here, but να βάλεις λίγο ζέλ. Πρέπει να μειώσεις λίγο το depth, Okay. Ναι, όχι. Έλα, λέει, το κάνω το λέω κανονικά, πήγαινε λίγο σε εξωφυδικά. Πήγαινε εξωφυδικά, Ελέα, πήγαινε εξωφυδικά. So, we see something that resembles the heart. Yeah. So, not the best acoustic window. Ναι, προσπάθησε να βρεις το χώρο. Sometimes it's best to rely on the hemodynamic measurement, but now the blood pressure is 130 to 67. You see there is not a lot of AI. Maybe a little, maybe very mild.
67, diastolic is, I think, very good.
It's 67, so I think we're happy with that. I think we're fine. So I think we're fine, I think. So it's there's no need to do something else. So do you have any other questions? You want to do another orthogram, or we're just fine with that? I think we gave a lot of dye, more than the one that the amount that we anticipated.
Well, can I comment, Yannis? That was a great case, and thank you for sharing. But this is a typical low calcium severe aortic stenosis that means mainly fibrotic, and I still believe that pre-dilatation would stabilize the valve better, especially in cases with low calcium. I don't know the panel's opinion, but I believe in that.
When you post-dilate, I think it's you always risk the...
No, pre-dilatation.
Yeah, the pre-dilatation, yes. The pre-dilatation
would stabilize
most of the times we do it, but when we anticipate an easy plantation, maybe 20% of the cases, as in this case, we don't do it. But this is by trial and error. So in hindsight, maybe we should have done pre-dilatation. I agree, because valve is unstable. Most of the times it's fibrotic tissue that that gives you this kind of headache. But yes. But that's the big advantage with this valve. It's receiveable, it's repositionable. You can place the valve in the in the designated place. So I think we will leave it there. So in case you need something else, Arik.
No, I think it's as I said from the beginning. It looked like a challenging case. With very, very unstable valve. It was just dancing from the beginning. I think the only way to implant a valve like this is using a pretty rapid pacing from the beginning. And I think that your pacing was unstable. At least twice, you go over it again and again. At least twice they jump because of a VPC due to wrong or whatever pacing by the wire. So, but anyhow, it was really challenging, and you had a nice result at the end. So, but you need experience.
Also, patient has deep sedation, so maybe it's something that we can discuss as well. Maybe avoid in certain patients deep sedation, and it's patient is snoring. It's a lot of thoracic movement, as in this case. So, on top of that, we had an unstable wire and an unstable thoracic movement. So it's it is. That was,
but it's definitely a teaching case.
Yes.
Very educational. And thank you so much for sharing.
Okay.
And we'll see you here later on.
Yes, see you later.
Yannis, congratulations.
Thank you.
Thank you, Teo. Thank you.
Congratulations.
Welcome.
All right.